Okay, thank you for coming here. I'm glad to be given an opportunity to share something close to my heart. As you know, I'm a medical doctor, and in my work, I take care of mainly older people. But as you take care of people who are older, you will have to take care of the family as well. And as you take care of sickness, you have to deal with aging. And as you do that, you will realize that aging does not begin at age 65. It begins when you're born. And then when you think about dying, you realize that dying is actually aging. And it begins when you're born. Yeah. And so in the place where we work, we take care of the older people. We started by taking care of people who are homebound. Since 1993, we started the first home-based primary care in Singapore. And over the years, we realized that you cannot just do that without dealing with the various psychosocial issues surrounding death and dying. So around around 2009, I got a grant to start an end-of-life care program, which is different from most hospices, which requires a diagnosis of cancer, terminal cancer. So we got the grant, and then I published it in the Singapore Medical Journal. The results are very good, because I will share with you, most people in the developed countries, we will become very old, and unless you die young, okay? So we'll become old, and it's very likely that if we don't take care of our health now, we will be quite disabled and frail and perhaps bedbound. And so you need to manage the process. So we developed that, and so it's quite good. So we are still doing that now in where I work. So I'm sharing with you the experience that me and my team gathered over the years on the ground, taking care of people who are dying, the people who are surviving, people who are aging, disabled, sick, or just aging without disability or sickness, and with or without dementia, and so on. So this is the culmination of the experience. So I'm going to cover this. What is caring? Okay. Then I'm also going to talk about what are needed, and I'll talk about something practical. So if you have to take care of somebody who is dying, how do you go about it? Okay. So. I'll be bringing in Dhamma as well, because this is a Buddhist crowd. If it's not a Buddhist crowd, then I'll remove that Dhamma away. But the same questions are still there for people to answer. Okay, if you don't have the Dhamma, it's very difficult to answer some questions. So what is caring? Okay. I prepared this talk long ago, and I used this picture. I was this Khoo Teck Puat Hospital. Minister Kaur was the minister then, so he was visiting. So I took this picture. So this picture belongs to me, and so no copyright issue. There are many things you can do about caring. So when people talk about caring, usually talk about the tangibles. But I really would like to question, where does caring begin? Okay, so what is caring? Is a doctor checking blood pressure from a patient caring? A lot of people nod their head, yes. Is a pest controller screening a home for bed bugs caring? A lot of people say yes also. But okay, I must tell you about the doctor checking blood pressure from a patient's caring. I have a friend of mine who is an anesthetist now. He's been an anesthetist senior consultant for a long time, but when he was a houseman, he was so tired, he was checking blood pressure, and he fell asleep onto the tummy of the patient. Okay? Then, of course, I've also encountered many times. I'm checking blood pressure, but I'm thinking of something else. And when I remove the cuff, I can't remember the blood pressure reading. Okay, then is pest controller screening a home for bed bugs carrying? Well, on the one hand, they are killing, right? They're looking for bed bugs and then they're going to spray insecticide to kill the bed bugs. Okay, but we have a private pest controller company that is so moved by the cases that we referred that they offer free bedbug treatment. It's $600 per session. You must do it 2 sessions, 1 week apart, because the eggs will hatch 1 week later, so you have to do it 2 times. And they do it for free for our patients. Is a construction worker laying the bricks caring? Yes. Yeah, but depends, right? Some are doing that and grumbling and thinking about meals, but some are laying the bricks and thinking that they are building something bigger, right? So it depends on the mind. Is a college student going on an overseas humanitarian mission caring? Yes, but you also, I'm sure you must have heard of friends or known of students who go for such mission like a robot, or just to have a cheaper tour or something, I mean, I used to do locum for a doctor in a clinic. She goes for mission trip in somewhere in Azerbaijan or, the Central Asian countries. And she got long queues of people and she measured the blood pressure and give high blood pressure pills. And then she comes back very happy about it. But at that time, I mean, I was not in public health, but I was already thinking, what is the good of that, no? I've done that before. I've done in the Tibetan refugee centers in southern India. We went there a few times over a series of 3 years. Every month, one of us doctors will go. We were asked by Venerable Lama Zopa Rinpoche to support the Tibetan refugees at that time. And the only thing they ask from us is money. The doctors notwithstanding, we go there and see patients and help them clear. But we can't speak Tibetans. They need to have a nurse to be interpreter for us. And whatever we prescribe, the real question is about sustainability, And so it was really quite thought-provoking for me, yeah. So in the end, a friend of mine, his mother donated $6,000 to buy computers. At that time, these are big deals. It's in the late 90s, early 2000s. So set up a cyber cafe where they can earn income to sustain their hospitals. Because they are refugees, the Indian government do not owe anything to them. So they survive on donations. Is domestic helper bathing a disabled elder caring? Yeah. Yes and no, yeah. Actually, that's the answer. I mean, you can have somebody bathing and showering, and then when they're transferring, because of the frustration, sometimes they can abuse can happen, even as you're doing the caring work. Okay. Is a nursing aide in nursing home distributing food trays caring? So I've got a student who was attached to us, and he was volunteering in some nursing home, and he felt they were quite meaningless. The people were all in a big ward because it's a nursing home. Until recently, most nursing homes runs like big hospitals. You just have a bed and a small cabinet next to you. There may or may not be a chair around you. And they were all, according to him, he described, everybody was just sitting on their bed in front with a cardiac table where the table is and waiting for the meals. And then the meals is being distributed onto a tray. And then some of them were like sleeping like this or just doing like this and waiting for the meal and then just eat. Okay? And he felt pained by that sight. So he came to us, and I gave him I commissioned him. Okay, you don't do these things, but what you do is I want you to get the life story of this gentleman. So that's how he did the volunteer work for us. Is an old lady bedbound from multiple strokes, not able to speak, wearing diapers, using feeding tube, caring? So this is a trick question, right? Say if it is yourself lying in bed, not able to get up and walk, you can't even speak, and you're receiving care. Can you care? Yeah. Yes. Huh? So whether is she caring or not is also yes and no. But we know, we know that, by now I think you should get what I'm saying is caring is a mind state. So a person can be lying down there. Yeah, I got this because I spoke with my teacher, Sally Dipankara, So I asked her about nasogastric tube feeding because at that time I was preparing a lecture about euthanasia, ethics, force feeding and so on. Say that, is it right for us to remove the tube or continue the tube feeding when the older person always want to remove the tube? And I was hosting a palliative physician from America at that time, so this was a hot topic. And so Siali told me, surprising approach she has. She just said that, well, you had to talk to her and tell her that she can send metta to the whole family, and that if she sends and the concentration is strong, people can feel it. So that was her answer to me. She didn't address whether she should remove the tube or not. But to a person like that, you had to care, which is enlightening for me, because for a while, I'm like trying to fix an ethical challenge, and I forgot the person who is there. So it's focus on the person, do that. Ethics is professor's problem, okay? To the person who is lying down there, how does she feel? What is the meaning of it? What is the value in my life if I'm lying down there helpless? Is there any value? Is a Buddhist monk meditating in the forest caring? So we know there are some people, even in the Buddhist circles, who think that a person meditating in the forest is a 自了汉, is a selfish practitioner. But how can you be so sure that a person who is going around busy doing humanitarian work, caring, when you don't read minds? Right? And when a person is practicing the forest, trying to live the Buddha's teachings, and to prove that it is efficacious, and that this is still preserved somewhere in the world, that the Eightfold Path is efficacious and can be practiced, and enlightenment is real and palpable, isn't that so much more valuable? And is there not an act of care? So this is the thing I'm trying to get at. Is caring a behavior or a mind state? So to answer the question, what is caring? So I'm giving you these examples for us to think about. So what would a caring person do? The answers to all these will be obvious, but I'm trying to explain about needs. Would a person who mentally decides and really sincerely care, would he care about others' needs? Yes. Would he or she care about doing the right thing? Yes. You cannot be caring and yet you just do what you want to do, right? You have to do what is right, right? Would you care about facts and truth? Yes. You want to know. You want to be humble about learning. You want to know what are facts, what are truths. You do not want to care from your own perspective. You have to search, when you really care, what is your mind state like? So would you be careful or careless? Okay. So this is an interesting concept that I learned from work. It's from Eden Alternative, which is a philosophy developed by a geriatrician in America. He defined caring as helping another person grow. And I felt this was really good to think about. Okay? So when you're caring for someone, or a dog or a cat, or caring for yourself or your parents, or caring for your children, what are you, what is your main objectives, what is your purpose? Okay? And when you get clear of the purpose, then you know what is required. And then you know what is the right thing to do. And you need to know what is the thing that you need to learn. Right? So if you really care, so when you put it like this, I felt it was really good. Then the question that a lot of people ask is, if a person is dying, what is there to grow? But the Buddhists will know, right? Yeah. So let's bring it down to something more tangible. So there is a blank here. How is it like for a blank when death is near? So fill in the blank. Someone you really care about, okay? So you can just, so maybe I can put my brother's name, okay, or my mom's name, or say you can imagine somebody you care about. What is it like for this person when the death is near? Because if we decide to care, to help the person grow, you will need to know who this person is, what are the needs, and then what do you need to do, okay? So everyone is different, so that's why you need to put a blank and put the name there. But there are some facts that are interesting for us for some guidance. This is a study by Joanne Lin using the Medicare data in America. So there are thousands and thousands of people. So it's published in 2002, but it's quite useful. They studied all the death of people under Medicare. So in America, there are two. The health is funded by two mechanisms: Medicaid and Medicare. Medicaid for the poor, Medicare for the old, okay, above the age of 60. So you get Medicare. So when you study the Medicare data, you understand the healthcare utilization patterns of people who are older, and this is the result. Most people, when you ask them, how would you like to die? They say, I just like to drop dead. I'm fine. Everything, I'm not afraid. I'm already done my dues. And like a friend of mine who is a senior doctor, so she has done, she has done a lot of practice. She just said that everything she can let go. When she dies, she can just die. Then I ask her a question, what if you have delirium, or your dementia? Anyway, I'm sure she has her answer, but you cannot control how you die, right? You can see from this data that only 7% of people drop dead. Okay? This, the far right, upper right-hand corner, that's 7% are people with sudden death. 22% are people with terminal illness. So these are examples are cancers. So the vertical line are the function, and then the horizontal line is time, right? So if you look at people who are dying of cancer, their function decline very fast and then they die, right? And then at the bottom right-hand corner are people with organ failure. So with time, sometimes, like for example, heart failure, kidney failure, chronic lung disease, you can have an insult to your body, such as an infection, okay, or overdosing on salt, eating too much hawker food, for example, then a lot of salt, then you drink more water, and then go into heart failure. So you go to hospital, the doctor give you some medicine to pass urine so that your body can clear of the water, and then you recover. But because of your old age, you never quite recover fully, and they discharge you because there's a pressure for bed, right? Then you go home, you feel you're better now, but you're still a bit apprehensive because you were breathless just last week. So you walk a bit slower. And by staying in the hospital for 3-4 days, your muscle is a bit less, okay? A bit weaker. Then you're a bit scared. Then you have a fall, but luckily there's no fracture. Then you really don't dare to walk anymore. Then unless somebody walk with you. So that's how declines happen, okay? So the bottom right corner is slow decline. They have a heart failure episode or lung failure episode or kidney failure episode, they drop to the bottom a little bit, but after a bit of treatment, they recover, but never quite fully. But because of the psychological post-traumatic stress reaction, they will decline further. And then another bout of heart failure or kidney failure or lung failure, drop a little bit further. And this is the decline. But the majority, 47%, is the far left lower corner. A dwindling kind of death where you will have one stroke then a little bit of memory problem, walk a little bit slower, and another stroke, then your memory is become worse. Then you start to become confused at night. And then you may start to develop dementia or Alzheimer's on top of the stroke disease. And maybe because of that, you don't have appetite, you eat less, then your muscle becomes weaker, you become frail. And then perhaps because you can't concentrate very well, you have a bout of pneumonia, you go to hospital, decondition further. So this is a dwindling kind of existence. So after a while, the caregivers are very stressed, they employ a maid. Then after a while, they find that, hey, very difficult, sent to a nursing home. Then nursing home, you find that this is the cause. So as a sidetrack, it is, of course, we know it's better to care for our elders at home, but sometimes it can be really tough. Then we have no choice but to go to a nursing home. And nursing home is not all bad. Some are really good, okay? So if there should be any effort, we should make aging and dying smoother as a society. So the implication of that data is that death can happen anytime, 7%. As long as there's even 1%, this is true, that death can happen anytime for all of us. Most of us suffer from chronic incurable diseases or frailty. So that's 100 minus 7, 93%. Most of us will not drop dead, okay? So if you think that you are very well practiced, you're very mindful, you can let go. Wow, after Dharma talk, very inspired, I can let go, I can drop dead. Only 7% you may drop dead. 93% you still have to deal with the suffering of aging, sickness, and losing your things that you cling on to. So yeah, so be careful whenever we have craving arising, attachment. So relatively long-drawn periods of disability and dependence before death, likely for members of the developed society. So long-drawn are the heart failures, the organ failure, and the dwindling death. Those are the degenerative neurological diseases. So 100 minus 7 and minus 22 is 63. Okay, then there is no, is it? Maybe not. Let me see. Yeah, 100 minus the top two is 47 plus 16. Yeah, correct. Is 63. There is still no way to know how each individual one of us will die. So we do not know how we will die. Okay. So apart from this. Okay, what I'm trying to answer is the question with the blank, right? How is it like for this person when death is near? So it could be drop dead, it could be cancer, it could be organ failure, it could be just old age dwindling. But how is the mind like? Okay, so according to Bill Thomas, I quote him again from Eden Alternative. He said there are 3 plagues of elders. It is not your stroke, diabetes, or hypertension, or hyperlipidemia. Diabetes, hypertension, hyperlipidemia. The doctors like to call them the DHL. DM, hypertension, lipids. All the older people all have this thing, you know. Sometimes I see, may not be very meaningful at the end of the life. But anyway, it's not those 3. What are the 3? Loneliness, helplessness, and boredom. Whatever the medical condition is, there is a mind that is dealing with it. So just now when we do metta meditation, we talk about, may this person be free from physical suffering, may this person be free from mental suffering. And this is some aspects of the mental suffering. Okay? So how is it like for so-and-so near the end of life? It could be those 4 kinds of death, but it could also be these emotions that they have. What would he or she need when death is near? What does one need when one is near the end of life? Okay? So, can think about it. What would a person need? Someone to change the diapers? Food, water? Yes, but not all, right? So, there's a piece of research published in the Journal of American Journal of Association. JAMA is American Medical Association, something like that. Journal of American Medical Association. So they did a focus group discussion on many people and found that what is most important for people with serious illness are control of pain and symptoms, avoid unnecessary prolongation of life, being a master of one's own destiny, so they would still like to have some control over what things are done upon them. Relief of trouble and burden on family, right? Strengthening of relationships with loved ones. Okay, so this is based on this piece of research. And there's another published data on also some kind of qualitative research on death and dying. So when hearing about the diagnosis, the attitudes of people around them, the doctors, nurses, and caregivers are very important. And the clarity of message and communication is crucial. Okay? Then, I'm trying to answer the question, what are the needs, right? So I'm using this Maslow's hierarchy. But there's somebody else in St. Louis. St. Louis, I think, is in near Seattle, Washington State. So they have translated Maslow's hierarchy into caring for people who are dying. So people need to obtain relief, to feel secure, to be listened to, and to maintain respect, and to share. Okay? So this is related to the Maslow's hierarchy. I use this a lot and it's quite useful, but I go beyond that. But I don't really have time to talk about those things. But it's important to don't just think about the physical, but also think completely, what the person would need. So we talk about how is it like for the person. Then I share with you the physical and then the mental states, right? And then what would the person need? I share with you some of the research data and also using Maslow's hierarchy. And because death is going to happen, and what would be a good death for the person? Is good death important? Yes, huh? But it depends, Depends on whether you believe in an afterlife. So it's very important. There are some Buddhists who don't believe, not just Buddhists, some people don't believe in afterlife. If they don't believe in afterlife, then good death, bad death is not that important, right? Going to die. I do have some friends who are Buddhists who will come and tell me that there's no need to believe in afterlife. Then I say that in that case, how would you approach a person who is physically suffering and want to kill himself or herself? Or let's say life is such a torture for yourself, and if you don't think there is an afterlife, how are you going to reason it out, not to kill yourself? But anyway, think about it. Maybe there are some other way to squirm around this question, but I think it is important when you're grappling with death and dying, you need to consider the afterlife. So whether you believe in an afterlife, so it could be heavens, it could be hell, and there are certain mechanisms around it. Okay? Do you believe in the existence of different realms? So this is Buddhist fellowship, so I'll be talking about Buddhism. So the Buddha talked about right view with taints, and wrong views in the Majjhima Nikaya. So what is wrong view? A person who doesn't think that there is a realm beyond the human realm. There is a result of bad karma done upon your parents, upon your friends or others. There is no afterlife. So that is wrong view. Okay. So let's say for Buddhists, we believe there is an afterlife, and then the afterlife has a mechanism. So based on that wheel of life, the dependent origination, but I'm just going to elucidate it here. So if you can see, starting with aging and death, okay, don't start with ignorance, start with aging and death. What's the cause of aging and death? It's birth. What's the cause of birth? It's becoming. Becoming is very profound. There is karma bhava and not karma bhava, it's kamma bhava. That means it is the becoming has got a volitional aspect to it and a resultant existential aspect to it. So becoming means becoming in any of the realms, but also the force, the karmic force that propels a person to that realm. So it is loaded onto that item called bhava, becoming. Okay? So what is the cause of becoming? It is clinging. What is the cause of clinging? It is craving. What is the cause of craving? It's feeling. What's the condition for feeling? It's contact. What's the condition for contact? It's six sense basis. What's the contact for six sense basis? Is mentality and materiality. Nama rupa. Okay, what is the basis for nama rupa? Is citta. Okay, and in the classical teaching, this is the rebirth consciousness. What is the condition for that? Is volitional formations of a previous life. And what are the conditions for volitional formations? Is ignorance. So, although it appears linear, but you know that in the teaching of dependent originations is many causes and conditions resulting in many resultants. So, while ignorance is there causing volitional formations, but it is implied also there's craving, there's clinging. Okay? And then there is an activity of the karma. So, I'm trying to say this to say that before the new rebirth happens, there's volitional formations. So at the other side, before birth happens, there's becoming. So in this cycle, there are three lives. You can see that a good death happens just before the new rebirth consciousness and before the new birth, right? So this is the area where death and dying you need to understand from a Buddhist standpoint. It's very profound. It's only one slide here, so anyway, we're talking about what is good death, right? So it depends on whether you believe in afterlife or not. And the next thing is, if you believe in afterlife and if you're Buddhist, then you need to believe in karma. You need to understand the efficacy of karma. Okay? So karma, volitional formations. Volitional formations carry karmic force. There are some priorities in the classical teaching. The weighty karma is the most deciding one. If there is any weighty karma, such as the killing of a father or mother, the negative one, or the positive one, attaining of jhanas. Okay? So those are the weighty karmas. If those are there, it will outweigh all the other karma. But most people don't have weighty karma, right? So habitual karma. So how you have led your life. What happens when somebody scolds you? Do you fight or do you try to understand that this person is in pain? Okay? When you see somebody in need, do you have a habit of trying to help, or do you have a habit of afraid that they're going to ask you for help? What is your habit in your life? Mental habit. Death proximate karma is those things that are surrounding the death period because they're closer to this dying process. And residual karma, whatever that is not in the habitual, maybe you don't have your habit is not very negative or positive. Most are quite general, and that around the death period, you have a sudden death, there's nothing very much going on around that. Perhaps you were just cooking, then suddenly you have a heart attack, Depends on what you're thinking. If you're cooking and thinking of a song, okay? Or maybe you're cooking and thinking, I need to add more, the fish is very fresh, my family will love it. There's a caring, metta, it's called karuna, then it's a good mind state. So it depends on that's proximate. But if it's something that you're just having a restless mind thinking of something, restlessness has very weak karmic force. Even though it's unwholesome, but it's very weak karmic force, then the residual karma will ripen, right? So what I'm saying is this, that if you're caring for somebody who's dying, and then and you want the person to have a good death because you believe in a good afterlife, and you're Buddhist, you remember the mechanism of it, so it's all karma related. So how can you help, right? But if you understand karma, you know that a lot of it is habitual karma. It's how this person has lived their life. It's not just what you do that last stage. So if he has a good death, it's not entirely you, okay? If he has a bad death, it's also not entirely your fault, right? So But if we want to help, we can act on that third one, the death proximate karma. Huh? But even better still, the whole life you have to protect people's mind, right? That's how we take care of each other's death, by taking care of each other's, whether they're dying or not. And don't just take care of their body. Always try to understand, try to be generous. Don't make people have unwholesome mind as a result of you, right? So caring for the dying at home. How can we help the person to have a good death? Okay, because good death, right? We want the person to have a good death. So how do we help a person to have a good death? Surely, it is a lifelong journey. So if you have a family or your friends, you want to help them to have a good death, it starts from now, right? Every day. Don't make them worry over you. Don't make them feel angry because of you. And yeah, so that is the thing we need to do. But what should we do when death is near? Okay. First, the most important is communication. Okay? But communication, where does it begin? A decision to care. When you have not decided to care, your heart is not open, your communication is superficial. You do not see the details of the person trying to tell you. And you have to listen not with your ear, but with your mind. What it means is, you have to, don't use your brain, use your heart as you listen. And you cannot just listen with your ear, use your mind. That means all the input from the sound, the sight, even the non-verbals, the mood, you have to feel. Okay? And you cannot just use your mind, you have to have wisdom. As you were to listen and feel and all that, your mind is always open with a question of why? What are the unmet needs? What is this person saying? What is the suffering here? So as you ask question, the mind, the wisdom happens, you know. As you become mindful, wisdom faculty will arise. It's non-verbal still. Wisdom is not a verbal thing like writing an essay is wisdom or saying a sentence is wisdom. Wisdom is no language. It is a clarity. You actually listen with clear comprehension. You're mindful and clear comprehension. Sati sampajana. Okay? Looking at this and see, every time whatever you do, you're very clear of the purpose and know what is the cause of thing to do, and then aware of the object, and of course always aware of the characteristics. Impermanent suffering non-self, but you listen deeply and try to gather what is the need here. So that is listening. Arts. Okay, I bring in arts because recently I was preparing for some presentation for the university, how they want to revamp their curriculum for medical students. I suddenly felt that actually doctors, not just doctors, you know, the healing profession needs a dose of liberal arts. And then later, NAC, National Arts Council, wanted to do some publicity about their arts program, so they interviewed us because we use it. And so I had to prepare to talk to them, and I felt that what I noticed in a lot of seniors is that the arts helps when words fail. Not just to express to others, but also to yourself. Like you were very happy, and then there's a song, and then you start to sing and dance. You can get in touch with the joy. But otherwise, you can just say, I'm very happy, that's it. Okay, then if it fails to express your joy. Okay? Or not just the joy, but also sometimes when you listen to a song, it appeals to a certain deep kind of mood of yours. You cannot just describe, but you're very touched and moved by it, and you get in touch with your emotions. So it helps in internal communication. But it also helps in external communication. I mean, there are a lot of, especially in the hospices, there are people who engage in arts therapy. So either in paintings or in music, And then the person is able to express many things that they could not express using their speech. Okay, so arts is a good tool for communication. And of course, in our current cohort of seniors, they may not learn the skills of arts, but you know what? Art is how you've led your life to, right? Our life is an expression of the arts. Huh? So, yeah. Anyway, so apart from listening, you have to invest time in listening. This is the most important before you speak. So when we speak, more than just the speech, the tone is important, the composure, the expression, the body language, and other non-verbals. So I'd like to share with you how you connect with a person. So when you have a person, you want to connect, and say some of you are volunteering in hospice, right? So you just sit there and talk, and they will smile at you because they are just being polite. You're nice to come and spend your Sunday with me, so I just be nice to you, and you sit around and you talk. But some of us are not trained and we do not know how to start. Some of us are trained, you have your own method, but I'm going to share with you this method. It's called Shift, Share, Shine, okay? First, you shift your focus. That means don't use your brain, use your heart. And don't think from your science. Shift so that you have to see how the world appears to this person. Share. What is share? Share is a decision to share. It's the same as we talk about decision to care. Sharing is to open your heart and make a decision to practice compassion. Okay? To share. In this particular teaching by OT, occupational therapist from Australia, compassion is defined as to enrich a person's life, another person's life. Okay, you can define compassion in different ways, but the share is just to open the heart and just make a decision to care. Shine. Shine is about shining your light. So this is also developed by this OT. But to me, from a Buddhist, I would say it's your shine the light of metta, like what we did just now. Okay? Visualize the person and just have the mind very, very peaceful and just reach out. As if you flood the whole room with light. Shine onto the person. Okay? And then, as you do that and then you listen, if the person is very quiet, you actually try to feel what are the unmet needs of a person. The unmet needs of a person, of course you can use Maslow's hierarchy, you can use all these things, but emotional unmet needs are postulated by a psychologist from UK. It's very practical, I find. There are 5 universal unmet needs. The need to care, the need to be needed and useful, the need to love and be loved, the need to have one's self-esteem boosted, and the need to have the power to choose. If the person, these needs are not met, the person is unsettled, is unhappy. So sometimes instead of giving advice, you ask for advice. Sometimes you come and talk to a person, instead of saying that, oh, don't be, let go, life is suffering, don't have to, okay. The person is there, I just feel that, can you please go away, okay? I don't need another teacher, okay? But perhaps you go there and, share some of the problems you have at work, in your family, and ask them for advice. Or maybe just tell them, and maybe they can have a listening ear. And, we cannot be contrived about this, but if a person can have the moment be a teacher or be a carer, it meets their needs, and we ourselves benefit from it. So anyway, those are the things, but I haven't finished it. Okay, after knowing the needs, how do you connect with the person? So that's the non-verbal. The teaching is, you have to be at slightly lower eye level than the person. So if the person is sitting on a wheelchair, you can actually sit on a low stool, or just sit on the floor, or just squat down or kneel down, so that your eye level is slightly lower, okay, in front of the person. And don't have to talk, just continue the shift, share, shine process. And the person find you curious, or maybe he doesn't care, he just look away. Then you mirror the person. If he's slouching, you slouch a little bit. He look up, you also look up a little bit. And then he look at you, you look at him. He look away, you look away. Then he scratch his face, you scratch your face. Okay? Continuously having the shift share shine. You cannot, without the shift share shine, you become a clown. Okay? So this mind state is very important, to be always like really trying to reach into a person, maintaining that wholesome mind state. And you do this. Then the person starts to say, who are you? I say, I'm so and so. How may I address you? Then he can reply, what are you doing here? Oh, I'm here to do this. What about you? Then he say, like that. Then you start to have a conversation. Okay? So that's how you connect, beginning with non-verbals. Okay? Then some people will ask, what if the person is advanced dementia, cannot speak already? You have to assume the person can hear. It is true, they can still hear. Okay. What if the person has got advanced dementia? They can hear but they cannot understand. No, you have to assume that they can understand. You have to assume that even if they have got dementia or advanced dementia, they can still feel. Okay, this is the truth, okay? People can still feel, they can cry. When they're angry, they may not have the language, but they will show you that they're angry. And then you may not understand this is the language of anger. You may start to dope them with medicine. I mean, that is because of misunderstanding. So people with dementia can still feel. And they have their thinking process. And it is different. Like a patient of mine with dementia, very worried about the daughter. The daughter has some other issues. So to her, the daughter is possessed by a bogeyman. And she sees the bogeyman in the house. And to you, everybody is very worried that this old lady with dementia is having hallucination, is mad. But if you understand the whole dynamics in the house, this is her expression of worry for the daughter. Okay? So the thing that comes out of them is symbolic. So that's why we should be trained in liberal arts. Okay? So for the elders, speak with a calm but moderately loud voice in a quiet place, assisted by appropriate aid. Okay, so when a person have got presbyocusis, okay, sensory neural hearing loss due to aging, because for the current cohort, because in their workplace it's very noisy, but for future cohort, which is us, it's because of loud music. Okay, so we'll lose our hearing. Then it's not that they can't hear, but they will be very easy. There's a lot of noise level. So to talk to a person properly, for people with age-related hearing loss, it's better to speak in a quiet room, no distractions, okay? And then combining both hearing and visual cues. So speak that they can see you, okay? Maybe touching. So they need all the sensory inputs to get the communication. And if you speak in a high pitch, it can hurt. So you have to speak in a normal tone, but louder, okay? And if there is a hearing aid, you can use it. So for those of you with caring for seniors at home with hearing impairment, you can buy, okay, hearing aid is not easy to use. You have to mold it frequently, and sometimes there's a feedback sound, and some older people don't like to use it. They have to go for molding until it's really fit very well. And to buy a good quality one, a few $1,000s. So, but if you don't want to invest in that, you can use an amplifier that is, you just Google and can be purchased quite cheaply, a few hundred only, $100 to $200. The one that we use in the clinic is called Pocket Talker, so very effective. So by doing that, you talk, oh, it's very clear, you can have a conversation. So some people have the dilemma, should I tell or not tell a terminal illness? So based on actually I got this from a slide from a pastoral care counselor from New York City, but there is no reference, so it's hard to say whether it's scientifically proven. But generally, people like to remain hopeful, and they would avoid having a death sentence. But on the other hand, people want to be prepared and be ready for planning. So there's a dilemma all the time. So it is always better to have some clarity. But some family is difficult to say. But even if you don't say, the person will know. So usually when we start to talk about this is to discuss in a general term to find out what the person already know. Then use that to develop. Because people need to know, Imagine it's yourself. Would you like to be hidden from all these truths? No, Same for your loved ones. They would like to know. It's just about how to tell. And after the telling, are you committed to support the traumatic, maybe first few minutes or hours? Actually, most older people, they are prepared. It's not as traumatic as you think. But younger people, yes, it's a bit traumatic. So you need to journey with them for a while. And people will come to terms with it as long as there's sufficient social support. We need to talk about it so that we can do advanced care plan. Advanced care plan is very important. It's about formulating a care arrangement and treatment for a hypothetical but highly possible future scenario. And it has got many values. I'll just read them. I mean, we're talking about the practical things, right? How to take care of a person who is dying. ACP can strengthen relationship, achieve sense of control. All these are evidence-based. Relieve burdens placed on others, enhance hope, strengthen patient-physician relationships, higher congruence between surrogates. Surrogates are like our donees. In our Mental Capacity Act, we have the older person can elect somebody to be the lasting power of attorney, and in the legal term, it's called donee. So these are surrogates in this particular slide. You help them to be their spokesperson, to decide on their behalf. But if you do not know what the person wants, when the time comes, it's very difficult for you to make decision for her or him. So ACP will help. So it also attains greater satisfaction with less conflict about these end-of-life decisions and less time spent in hospital, more deaths occurring at the patient's place of choice, usually at their homes. And it's a compilation of all the various small and big qualitative and quantitative studies. So these are the conclusions of a compilation of studies. So ACP is very valuable. Advanced care plan is very useful. It begins with good communication and open, but you have to be ready to journey with the person, to take the initial stress. Okay? So family communication is very important. A lot of us are not prepared to be caregivers. A lot of families are loving, are very cohesive. But when it comes to a crisis, they do not know how to start also. And they don't know how to discuss. And sometimes they make assumptions. And sometimes as a result, there are friction. So family conference is important. So as a doctor, with the team, I would usually, this is one of the most important intervention I can benefit a patient, which is to call a family conference and to be a facilitator, or the social worker can be a facilitator while the doctor be the resource person to provide information. So we'll call for this. Usually after family conference, there's a lot of peace and happiness, A lot of the unsaid are opened out and communicated, and the burden is relieved. So if you're in a position of caring for your family members, and you find that the family seems to have something that is an elephant in the room that is never really discussed, you should talk to your primary care provider or the doctor who's been caring for your elder at home, that can you help us with a family conference? It will be very helpful. So we can clarify many things. So physical care, you have to take care of the meals and fluids, so give people the choice, proper amounts according to physiological and disease conditions. When a person is dying, you don't want a lot of water, and we also do not want a lot of food because it's very difficult to digest and it's a burden. Imagine you're sick with the flu. Do you have appetite? No, right? So, and if you're forced to eat a lot, is it suffering or happiness? It's suffering, you know. So we want to cut down on food and water. Basic activities of daily living. So when you take care of a person who is dying, you need to learn the physical aspect of care. How do you turn? How do you sit? How do you feed? How do you transfer? How do you push a wheelchair? How do you do dressing if there's a wound? How do you manage the bowel and the bladder? How do you provide showers? Okay? And you help the patient help himself. So a person who is disabled would still want to help himself. If a person totally resigned to it and just let everybody help, there is maybe some unhappiness there, you know. So it's always better to help a person to help himself rather than take over everything. Learn caregiving skills from nurses and therapists and encourage exercise and rehabilitation. Instrumental activities of daily living. These are all medical terms. ADLs are basic activities. Instrumental are those that requires people to live in a community. So things like buying groceries, house chores and all that. So if a person needs help, then we can support this. Optimize self-management using special phones. Those sets are pill boxes to help a person organize their medicines. Motorized wheelchair, webcam, you know. When a person is dying, they may not be big, but at the time they could be still walking very slowly. So they need help in grocery shopping, telephone calls, and cooking. So these are the things that we need to do. And provide assistance when needed. And now with MCA Act, we should all get an LPA. If the person is still having capacity, we should get the lasting power attorney done. So after that is done, and then they do their will, they will be quite peaceful. LPA, will, and ACP. This will help a person relieve some of the attachment they have about many things. Healthcare. A lot of people see the doctors and they just listen to the doctor and they come out and then they don't know what the doctors say and there are lots of questions not answered. So if you are helping a person to see doctor, be their voice, okay? But do it politely. Some doctors are, ego very big one, okay? But generally, they will be very helpful. So you speak very nicely. After the consultation, you should ask the doctor, what is the diagnosis? What is the prognosis? Prognosis in the sense that what is the chance of recovery or outcome? A lot of lay people think it is about 3 months, 6 months. It's not like that, okay? The doctor will usually say 3 months, 6 months because patient wants a number, okay? But in actual fact, no one can predict so soon, okay? Generally, it's like this. We can only say that most people, majority of people may pass away within 6 months, but there are some people who can go beyond. Sometimes we will say that we don't even be so clear of 6 months because, we can't tell really, you know. We can only say it's in terms of weeks to months, or months to years, or if it's really eminent, we say it's in terms of days to weeks. Sometimes when I see a person's blood pressure dropping and the breathing pattern is different already, I would say maybe in the next 1 to 2 days. Okay, so it's not easy to make this kind of prediction, and people take this word very seriously, for lay people. But this is important. So it's called prognosis. To talk about how the chance, the term is called prognosis. So we need to ask the doctor, what do you think is the prognosis? Okay. What are your treatment plans? If you are a old lady with a daughter coming to see the doctor just say that, there's a growth there, so we will try our best to relieve the symptoms. You may have pneumonia, then I'll give you a treatment. If any problem, you just go to the emergency room. Any questions? No, okay, bye-bye. That's it, okay? So if you don't ask, you don't know what's going on, right? So you have to ask. Okay, so what is your diagnosis? Then the doctor, oh, diagnosis. Okay. Then they'll hide behind bombastic term. It's an adenocarcinoma of the lungs. Okay. Bronchogenic carcinoma. But you have to say, okay, it is a cancer, okay, of the lung. And based on the recent scan, it has spread to the brain and the bone. And then what is the prognosis? Okay, metastasized cancer. So the chances is not good. How long? Okay, then the doctor will say, well, it's very difficult to say, but I would say in terms of weeks to months. Okay, but that's all. I cannot tell you more. Okay, then I say, what's your treatment plan? Well, I will need to consult an oncologist colleague. I'll write a memo you have to see, and then they'll explain to you what the treatment options. But if the doctor is an oncologist, he'll tell you, you can do this or that, and the chance is like this. They'll give you percentages, but percentages is also quite meaningless to us, right? But the doctor will say percentages and what are the various treatments and what are the side effects. Then, so you have to ask him. If he never say side effects, you must ask, and then you have to ask what are the things to look out for, because the doctor is not going to stay in your home, You are staying with your mom, so you must ask, so now I'm taking her home, what should I be looking out for? Then the doctor will find that, hey, these are all good questions, how can I never think about? Okay, if you feel that, if your mom is having breathlessness or coughing, then you should come to the emergency room. If your mom, then what about pain? Oh, if there's pain, I'm going to refer, then maybe because of your question, it reminds him I must refer to a palliative care team. So you ask about these questions. What to do when this or that happens? So for example, if they cough blood, what do I do, right? When should I send him back? When should I send to the hospital? So you have to ask these questions to the doctor. And the doctor will be very happy to work with you, because you are a caregiver who is practical. Okay, you're asking questions that are practical. Some doctors will ask the nurse to do this because usually the nurses know better. They have more practical experience. So nursing care, although we are not nurses, but we can learn nursing skills, learn from the nurse, manage toilet needs. Like as a doctor, I must say, I've only showered a patient like twice or three times in my life. I do not know practically how to shower, okay? Change diapers, okay, I've done it before, but a lot of doctors never change diapers before. So you need to learn, not from the doctors, but from the nurses. Oral care. How do you clean somebody's teeth when they are not going to brush their teeth? Skin care and wound management, exercises and range of movements. Sun exposure is for vitamin D, but depends. If a person cannot sit on a chair, after sitting there's a lot of pain at the back, then you cannot do this already. Daily living as normally as possible in a familiar environment, surrounded by familiar faces. Be close to nature if possible. Okay, there's a lot to say about this. The patient doesn't want to be, like, just because I'm dying, I'm no longer your mother, I'm no longer your father. Like a lot of the patients would tell me, the grandchildren come, they don't dare to walk into the room to see grandfather. They just look at grandfather like this, they are a bit, actually they are not really scared, they just do not know how to do what they are supposed to do, then they don't engage. So we have to help the family members to adopt and adapt and accept and remember dad is still dad, mom is still mom, grandfather is still grandfather. So you still have to connect and just like a family. Then home safety is important, but there is no need to be too risk averse. There has to be some spontaneity, allow some risk taking. Like for example, when a person is diabetic, oh, cannot take durian, you're going to kill her. No, okay, no problem. Don't have to be so safe. Eat a bit of durians, a bit of cake, small amount, whatever they can take. Some people have got fall risk. Because of that, cannot walk at all. No, if once a person wants to walk, you should actually help them to walk, If the person wants to go out under the sun, cannot, you're going to have, there's a lot of haze. Okay, okay, never mind. You want to go to the sun, right? Okay, go out for a short while. So don't have to be so risk averse. Last few slides already. When the needs are met, the person is less likely to have negative mind states. So we still want to talk about good death. What is the meaning of nursing care, medical care, and all that? Because when you meet all these needs, it's less likely the person is unhappy. Okay, you can talk about Dhamma, but the person, he's got pain. Your Dhamma falls on deaf ears. Chances are, unless this is a very well-practiced person, he can observe the pain and see, 4 elements. But most people, no, okay? Then you have to relieve the gross suffering. So it's important. So that you don't have so much negative minds, right? So good mind states before death. Remember the dependent origination. So volitional formations before the next rebirth. Forgiveness and acceptance. This is metta or adosa. No hatred. Okay? Contentment and gratitude. Contentment is aloba, no greed. Gratitude is wisdom. But even better, clarity. And you can lie down there and it's all clear. Life is just like that. Arise and pass away. All the whatever, you have been a manager, have been a CEO, have been a doctor, have been a nurse, have been a teacher, you've got so many children, all these are just arise and pass away. It's also like that. Why is it like this? Because it was like that. Okay? Why like that? Because of like that. Why am I like this? Because of like that. It's all very clear. And what will happen to me? It'll be that. Okay? Sure. So all this clarity is not on the last thought moment. It's all how you have learned, whether you attend the Dhamma class, you study the Dhamma, you practice meditation, you practice deep vipassana, samatha, so you practice. That will help, in the last stage. But there's no guarantee. Okay? Conclusion. Needs are different for everyone, but general trends are still useful, using Maslow's hierarchy. To care is a mental decision. It is not just an action. Caring for the dying begins with knowing the needs. Knowing the needs begin with communication, which is not necessarily verbal. Listen with our ears, our eyes, and our hearts. A care partner or a caregiver attempts to know the needs in order to meet them. We meet the physiological needs in order to care for the mind. We care for the mind in order to take care of the mental volitions near death. All the above just to support a good rebirth. Why do we want a good rebirth? That's all I have to share today. Thank you very much.
Thank you,
Are there any questions? Yeah.
If you have any questions, just put your hands up and I'll come to you with the mic. Mr. Chan.
Yeah, thank you, Doctor, for the very enlightening and practical talk. Actually, I got 2 questions. One is more a technical one, and the other one is not. You have used the term "use your heart" many times. Use the heart, so that's good. But when we say we use our mind, usually the mind will work through the brain, to function, right? So medically or technically, scientifically, when you say use your heart, how does that process function? That's my first question.
The mind is at the heart, not in the brain. Simply put.
So that means it's still the mind that is going through the brain to work, right? It's not, you can't, because the heart has got no neural function, right? So it's still the mind that's working, right?
It's something quite difficult to explain, but when you're happy, where do you feel the happiness? Here or here? Okay. When you are down, unhappy, where do you feel the downness? Is it here or here?
The whole body, I don't know, for me.
I don't know how to explain, but if you practice meditation again and again, and you will realize that when you want to observe the mind, the most immediate place to observe is here, not here. Oh. So when when we say open your hearts, speak from the heart, feel with your heart, I really mean open your mind, speak from the mind, and feel with the mind, and I really mean it here.
Okay, my next question is about this gap, usually gap between the caregiver and the patient. You have already given us a lot, too much to digest in fact. So I just want to focus on one aspect, one particular aspect. Say somebody has got a stroke or a heart attack and is dying, okay, then usually there's a mix, some will be positive, some will be negative. Kind of attitude with the patient,
yes.
and then the caregiver would like to have a positive outlook of the prognosis. So what are the three most practical things to focus on in order to narrow this gap between the negativity of the patient and the positive mental attitude of the caregiver?
Oh, you're saying that if I get your question correctly, it's not about prognosis, but it's about mind state, right?
Yeah.
The patient may be negative or positive. The caregiver may be negative or positive, and the caregiver could be positive. The person who is dying may be negative.
So how do you narrow that gap? The three most practical aspects to focus on. I think you have given us a lot, too much to digest.
Yes. So when we talk about negative and positive, what do we mean? But what I think it means, a positive means a wholesome mind. A negative means an unwholesome mind. Unwholesome mind is one with greed, hatred, and delusion. Delusion can be restlessness, can be boredom, which is a kind of restlessness. Worries is a kind of aversion. Anger is a kind of aversion. Attachment, cannot let go, is a kind of attachment. Conceit, being proud that people, why are you speaking to me like this? Who are you? You know, that is a kind of attachment. So negative are all these kind of meaning. Okay.
Can I just focus on, I'm going to die, you know, I'm not going to have a long life, just focus on that.
So, if a person is going to die, but at the time he's very peaceful, he's positive. But if he's focused on the life and then he's negative, maybe he's thinking that he cannot let go. He cannot let go of certain people, or that he cannot forgive himself for certain things. So, I'm trying to narrow negative mind into the bare basic, which is greed, hatred, and delusion, actually. Okay? Then caregiver positive. I would like to narrow positive means a mind that is non-hatred, non-delusion, and then non-greed. Okay? So how do you influence a person with negative mind from a person who is positive mind? So, which is actually this lecture, but as I say, it's actually very complicated. So first, you have to meet the unmet needs. To know the unmet needs, you need to really feel with the heart what are the unmet needs. So with some knowledge, it could be related to physical pain. It could be related to hunger. You have to meet them. Okay, so you have to see this person may need morphine, then better need morphine. If I don't know how to treat, I better get a doctor to come. Then person may be uncomfortable lying down for so long. I need to learn the skills of turning. I need to use a proper mattress. Maybe I need to have some fans, a bit too hot. Or maybe it's too cold. I need to make it a bit warmer. Okay? Then these are physical. Then maybe there's still these negative emotions of fear and all that thing. The person needs to feel secure. If it's in a hospital and the place is very, scary, or a lot of people crying and dying and all that around them, maybe it's better this person is nursed in a different place, perhaps a hospice or a home, to feel secure, surrounded by family. And the family, how's the family like? The family, everybody is quarreling, who is get this house, who get that house. No, the person doesn't feel secure. So the family need to be harmonious. Then we need to do a family conference, talk about it. Okay, then settle things down. There's a lot of commitment required, competence, and then confidence as well. So support everything, right? So security. Then after that, the person needs love. Okay, so the family need to come together, support the person respectfully, so that there's self-esteem boosted. You can talk about things like, thank you, you have been a wonderful mother or a father and all that, to boost the self-esteem, So self-esteem is related to conceit, is negative. But sometimes you need to satisfy these before you can get rid of them. Okay? You cannot tell a person, let go, all of us are nothing. No. Huh? So these are not, so you have to do it very, it begins with with communication by listening to know what this person really need. And then is this physical, is it security, is it due to love, self-esteem? Is there an opportunity for her to share, to grow, to be needed and be useful, to have a choice? Okay, and then when all these are met, at least the craving subsides, the anger subsides, the craving is not there. There may or may not be delusion. And that depends on the person's past practice already. Not entirely, it's up to us. Okay? So maybe around that time, if you're very peaceful, skillful, you can sit around them, and then you may like to, would you like to learn meditation? Today I learned a technique. Oh, sure. I did this for my mom, you know. I mean, she's not dying, but she's very, she doesn't like anything to do with religion. But on good days, when everything's met, she's very open. I can talk about this, you know. Then I share on loving kindness meditation. Then she'll sit with me and we just do this. So same. When all the needs are met, the conditions may be right. There's no guarantee. Depends on your relationship also. So that's when you can start to practice loving kindness meditation. Loving kindness or mindfulness on the breath. And then after that, maybe the person say, okay, go la, gao liao. What are we having for dinner? Then he's smiling. So you see, you actually help him from negative to positive already. So very, very slowly. Then after that, you can go for dinner or go for something. And then other times, you can just be mirroring, you know, shift, share, shine. The person starts to feel kind of comfortable with you. They may talk about many things. You know what? I'm worried about younger sister. Why are you worried about her? You know, Sheila like that. Oh, okay, you don't have to worry. I know about this, about her. She's okay one. Oh, really? Oh, okay. So it's through all these daily activities that things are solved. So, to summarize, how do a person's negative and you're positive, how do you help? It is through this relationship, okay? That there's no formula. But you have to be sure that you're positive. Some caregivers are not positive. We have a lot of attachment, we have a lot of anger. We have to take care of ourselves, especially the mind. Yeah.
Thank you.
I think we have time for one more question. Also, Dr. Ng, someone requested if you could share the conclusion slide preceding this. I think it's very informative. They want to take photo.
Okay.
Dr. Ng, is there any difference, caregivers' advice for patients or people who die young? I mean, yeah, now we are like more on the older people.
Yes. So the principles is the same. The principle is the same. You have to see what the person need. When a person is young and dying, the need is different from a person who is older. But the needs, generally, the trend is still the same. That everybody, there's a physiological need. There is a security need, love, self-esteem, and self-actualization, which is to share. And but the thing is, for us, we need to understand them. So we need to invest some effort in listening. Sorry, let me just open this slide first, then I will answer the question. Okay. Sorry, if you're caring for a person who is young, it still begins with communication to listening. So listen not just with your ear, but with your heart and minds. Not with your brain, but with your heart. To really know how the world appears to this young person. So use our intuition. And then by listening and journeying with a person, not just one time, but across a period, when there's a relationship especially, we'll know what are the unmet needs of a person. It could be physiological or security, but it could be emotional. Needs to be needed, needs to care, needs to love and be loved, needs to have the self-esteem boosted, needs to have the power to choose. And then to see how we can meet those needs. And these needs may not be met by ourselves alone. It could be the other family members or some friends. Art sometimes can help for a person to express whatever it is. So through the expression, they can actually have insight into their needs as well. And some of the needs are met by themselves and not by us. So through arts that they can know it. and the principles will still be the same. So it's all about communication, actually. And it's about relationship. Yeah. Yes.
Maybe this will be the last one.
Doctor, I want to ask you, now we know due to our lifestyle, 1 in 4 of us might get cancer. And a lot of us also explore alternative treatment. What is a Western trained doctor's point of view in merging alternative treatment with Western treatment?
Okay. Okay, nowadays cancer is actually medical science has advanced so fast. A lot of cancers are chronic disease. It may not kill you. So it's important for you to seek professional advice by oncologists. And it's a very specialized field that a general doctor like me, I won't be able to answer in detail. Alternative medicine, there are a lot of research on it as well. But I do not know that it has been, the evidence is very strong. So as a doctor, I would not advise against or for it. But what I would advise is getting the mind into positive territory. Even as you're healing, okay, receiving treatment, alternative treatment or Western traditional treatment. And so that is what I would do. Yeah. I didn't answer your question. I can't.
All right, thank you very much. Thank you, Dr. Ng. I think if you have further questions, I think this topic is very interesting. So please stay back, join us for lunch, and I think Dr. may stay around for a while, mingle with all of us. So please bear with me as I take you